In this lecture, we will discuss Torsades de Pointes, including its pathophysiology, EKG features, potential causes, and clinical significance. Torsades de Pointes, or simply TDP, is a form of polymorphic ventricular tachycardia. If you recall, polymorphic VTach occurs when there are multiple ventricular foci resulting in varying QRS amplitudes, axes, and durations. Okay, so if you imagine here, we have these multiple different foci in our ventricles, okay, few down here occurring. And because of that, we have multiple foci. We're going to have different QRS complexes, okay? So you'll notice here the amplitudes are changing, the axis will change, and so will the durations of these QRS complexes, okay? Now, TDP occurs in the context of QT interval prolongation. Remember, the QT interval is from the beginning of our QRS complex to the end of the T wave. And torsades has a characteristic morphology in which the QRS complexes twist around the isoelectric line, okay? So again, the QT interval is from the beginning of our QRS complex, this point here, until the end of our T wave, okay? So remember, that includes ventricular systole. That's our QT interval. And we're saying with torsades, what's specific about it is that we have a prolonged QT interval, okay? And what we're saying with this torsades that's characteristic is that it twists around an isoelectric line. So if we draw maybe a line through here, you'll see that the QRS complexes are pretty much twisting around the complexes, okay, around this isoelectric line. So sometimes if you draw this like that, okay, some people consider this to be somewhat of a bow tie, you know, if that helps you remember, okay? So you pretty much have these complexes that are just twisting around this isoelectric line, okay? So that's what it appears like. So just so you're aware, in order to make the diagnosis of TDP, you need to see evidence of both polymorphic VTach and QT interval prolongation. Okay, so how about the pathophysiology of this rhythm? Well, we said that the QT interval must be prolonged, which reflects prolonged myocyte repolarization, okay? And this is due to an ion channel dysfunction. The prolonged ventricular repolarization can give rise to early after depolarizations, which may appear as tall U waves or premature ventricular contractions, PVCs. It is from what is known as an R on T phenomenon that gives rise to TDP. In other words, a premature ventricular complex occurs during the preceding T wave, thereby initiating torsades, okay? So this is what we call R on T phenomenon, okay? So if we just erase some of this here, we're saying that we have a prolonged QT interval, okay? So imagine that this QT was prolonged. In this case, it's not, but let's assume it is. And what you have going on is that you have a PVC or an R wave of that falling on top of this area, okay? So it falls in this area, and after that, it precipitates out the torsades that we saw there, okay? And that's what's going on. We call that an R on T phenomenon. And you can imagine that the greater the QT interval, the greater the chance for a PVC to fall in this region and precipitate out the rhythm, okay? Another thing to note is that the onset of TDP is often preceded by a short, long, short R to R intervals, which is referred to as a pause-dependent TDP. And the longer the pauses, the faster the runs of TDP. So what we have is a short QT interval, okay, imagine that. Then we have a long, okay, and then there's a short one. And it's after the short one that we tend to have that TDP precipitating out from that place. Now, what we mean by this R, you can think of R on T like our, let's just erase some of this here. You have an R wave, think of your PVC, a premature ventricular contraction, the R wave of it falling right on top of the T. Okay, that's what we mean by R on T phenomenon, and that's what precipitates it out. All right, now in terms of causes of Torsades de Pointes, there are many. Some of them include electrolyte disturbances such as hyperkalemia, inherited genetic mutations such as channelopathies like in long QT syndrome. There could be medical conditions. You can see a prolonged QT and hypothermia, and that may, again, if you have a PVC that falls on that area, you can precipitate this out, as well as multiple medications can cause it, such as macrolide, tricyclic antidepressants. Among other antidepressants, you can have antipsychotics, antihistamines, antiarrhythmics, chloroquine, hydroxychloroquine, among many other medications. Clinically speaking, torsades is often short-lived and self-terminating. However, it may be associated with hemodynamic instability and collapse, and it may degenerate into ventricular fibrillation. Being Being able to recognize TDP is important as it allows for initiation of specific management, such as giving the patient magnesium, overdrive pacing, and so forth. Okay. So just a few helpful tips that we can go over before we end here. So first off, the twisting morphology that's characteristic to this rhythm may not always be seen during short runs or on a single lead recording. If the rate is above 220 beats per minute, the longer the rhythm lasts, the greater the risk of TDP degenerating into VFib. The presence of abnormal or giant TU waves may precede torsades, especially in patients with long QT syndrome. And lastly, bigeminy PVCs, which are PVCs that occur every other beat in long QT syndrome, may be a clue that TDP is imminent. All right, let's briefly go through our chart here to make sure we didn't miss anything. So again, Torsades de Pointes, or TDP, is a form of polymorphic VTAC, okay, occurring with this prolonged QT interval. So you need both the polymorphic VTAC and a prolonged QT, right? We saw multiple ectopic foci firing within the ventricles. We have, it's actually means twisting of the points, which can help you. The QRSs are twisting around that isoelectric line that we saw. You have an undulating sinusoidal appearance with QRS axis that's changing from positive to negative and back and forth, okay, in this haphazard fashion. We talked about the pathophysiology. The prolonged QT interval is due to prolonged repolarization secondary to an ion channel dysfunction, right? And after that, we can have these early after depolarizations, such as tall U waves or PVCs, that then lead to this R on T phenomenon in which a PVC can fall on top of a T wave and precipitate out this arrhythmia, okay? We also mentioned this pause-dependent TDP, which we have this the TDP is preceded by short, long, and short R to R intervals, okay? And the longer the pauses that we see, the faster the runs of this arrhythmia. We mentioned a number of causes, and clinically, remember, this is short-lived and self-terminating, but it is and can be associated with hemodynamic instability and collapse. It can convert back to normal sinus rhythm or degenerate out into VFib. Now, obviously, this rhythm is irregular. The rate often tends to be between 200 and 250 beats per minute. There's no P waves. We can't make anything out. Because there's no P wave, we don't have that P to QRS ratio and no PR interval. The QRS interval, because it's originating from multiple different foci, we said it can be variable. There is, in terms of grouping, it's variable sinusoidal pattern that we saw here, okay? And there will be no drop beats. Well, that's the end of this lecture. We discussed Torsades de Pointes, including its pathophysiology, EKG features, potential causes, and clinical significance. I hope you learned something.